Hello everyone. So welcome to my channel and I'm Dr. Saurabh Dixit and today I have just got a small crisp session on abdominal trauma. So today I would be discussing with you how to approach abdominal trauma because abdominal trauma is a very commonly thing when you talk about the surgery residency, and it's also a very common question when you are talking about MBBS, your exams, and when you are talking about the MCQs. Again, you get the questions on abdominal trauma everywhere. So I'm just trying to make the things simple, very simple for you. So whenever we talk about the abdominal trauma, the very next thing that we need to understand is how to evaluate this abdominal trauma. So evaluation of abdominal trauma is very important. So a patient has been brought to ER. Now how are you going to approach this patient? The first thing is you need to resuscitate the patient, and for resuscitation you need to establish the IV access and then start with the fluids. We know this. Simultaneously we will be doing a primary survey for this patient. So students, you have to understand that primary survey and resuscitation, this is done simultaneously. So this is what is very important. So whenever a patient is brought to the ER, the next thing is resuscitation. And not only resuscitation, the patient survey is equally important. Now, when you're talking about resuscitation versus patient survey, which is done prior, which is done later, answer is both of them are done simultaneously. Primary survey, as you all know, is again of two types. We have two things to be understood. We have the patient survey as primary survey, and we have the secondary survey. So primary survey is one thing, secondary survey is another thing. What is primary survey? In a nutshell, it is the first clinical assessment of the patient. So the first time when you are seeing the patient, you are assessing the patient, your aim is to save the life. And thus you are going to look for those critical things. So the first clinical assessment that is done, that is what is the primary survey. And what is the secondary survey? You need to take out an information which could modify the outcome. So this is the assessment, this is the clinical assessment done post hemodynamic stabilization. So clinical assessment done post hemodynamic stabilization. This is what is secondary survey. On this we shall discuss in detail and depth later on, but just to concise it, primary survey, we follow the concept of CABCDE. What do you mean by this CABCDE? The first thing is, your priority of any survey is to make the patient, you can say, come out of that danger. So here any life-threatening injury should be ruled out. So before you start with any survey, the first thing that you need to understand is stabilize and secure airway. So stabilize the C-spine, so stabilize the cervical spine, and along with that secure the airway. Now when we talk about cervical spine stabilization, why it is important? Because it can cause a cardiac arrest. Why you need to secure the airway? Because the most common cause of early death is an airway compromise. So secure airway and stabilize the cervical spine, and then start with CABCDE. Now when you talk about the CABCDE, what does this C means? Does it mean circulation? No. The answer is control any catastrophic bleeding. So control any catastrophic bleeding. This is what is known as the perspective of, or this is what is C in the CABCDE. And then A for airway, B for breathing, C for circulation, D for disability, and E for environment. So you need to expose the patient. Why you need to expose the patient? Because suppose the patient has been brought to you with abdominal trauma, there could be a possibility that patient might be having concomitant thoracic injury also, head injury also. Suppose there could be a leg fracture also. So you need to expose the patient to rule out other possible sites of injury. And in certain cases, like in cases of burn, so you need to expose the patient to get rid of that contaminated, you can say, clothing. Also, suppose it's a case of immolation. Someone has sprinkled down gasoline product and then set himself or herself on fire, and then you need to clear that toxic lethal environment also. So you need to get off that clothing so that the contaminated clothes are removed out. So clean environment, and E also stands for exposure of the patient. Now when we talk about the concept of secondary survey, It is nothing but ample. Now, what do you mean by ample? Ample is nothing but it's an information derived to, you can say, modify the outcome. So, A, you need to identify the allergies. M, you need to assess what the patient medications were, or if the patient is having any special medication being added. Why? Because there could be a possibility that patient is diabetic, patient is hypertensive, patient is on, you can say, anticoagulants. So, it's very important that these drugs should be added, or whatever planning is done, we need to include these things. Then the P in this stands for the past history. Now, past history means past medical history. L is the last meal, and E stands for the events of trauma. So, this information is what we seek once the patient is hemodynamically stable. Now, when we talk about the abdominal trauma, now how to approach this abdominal trauma, this is what is very, very, very important. Now, in case you have a patient of abdominal trauma, the first thing that you need to understand is that whether the patient has a penetrating mode of injury or whether the patient has the blunt trauma. So, penetrating versus blunt trauma is very, very, very important. So, penetrating and blunt trauma is important. So, we need to understand what is the mode of injury. Now, you will say, what is the difference? Yes, I will tell you the difference. The time. The time is running very fast for penetrating injury patients. So, you need to ask them one more question. What is that question? The question is, what is the status of the patient? What is the status of the patient? Because if the patient is a patient of penetrating injury and the patient is unstable, what is the next thing that you need to do, students? Answer is plan a surgery. Why? Because this is penetrating injury, patient is unstable, you cannot wait for any diagnostic test to give you result and then you will decide. What surgery you will do, you don't know. So, you are going to explore what you are going to do. You are going to explore the abdomen, and opening of the abdomen is stomy. The Greek word or the Latin word for abdomen is lapro, and that is why, students, this is known as exploratory laparotomy. So, what is the concept of exploratory laparotomy? This is what is exploratory laparotomy, and it's very, 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 very important. Now, when we talk about if the patient is stable, what to do in this case? Now, you have a window of just going for a CT scan. The CT is very important. Now, you could say, sir, for unstable patient, we could have gone for CT. Try to understand the rule. The sigma rule is, in unstable patient, whatever has to be done bedside, or you need to take that patient to OT. Now, if you talk about unstable patient, how can you get a CT machine bedside? And the ultrasound that you talk about fast is not conclusive of any organ injury. I'll tell you about the fast, that is focus assessment sonography of the trauma. It's only a tool to tell you whether there is important significant collection inside the abdomen or no, and in case there is significant collection, you plan a surgery for them. This is the only thing that fast can tell you. So, try to understand. We go for CT. On CT, if there is injury, you go for surgery. If there is no injury, you can continue the conservative management. Now, here again there is a call. What is that? Important, very, very, very important, and this has been a question also last year. Penetrating injury with any of them. Now, what do you mean by any of them? This is what is very, very, very important. So, penetrating injury with any of them. What is that any of them? First is evisceration. This is evisceration. So, penetrating injury with evisceration. The second is impaled object. Impaled objects. What do you mean by impaled objects? Someone stabbed over the abdomen, left the weapon there. Third is peritonitis. So, patient with peritonitis. The fourth is gunshot injury. Gunshot injury. And fifth is bleeding via natural orifice. So, bleeding via natural orifice. Now, this is what is very, very, very important. So, students, try to understand, any patient with viscera protruding out, gunshot injury, you will not wait for the patient to become unstable. Why? Because if you talk about a gunshot, the bullet has gone and grazed off the bowel and there is a pinpoint injury. Slowly, feculent matter is leaking out and a patient develops feculent peritonitis. Do you know, now when you do laparotomy, the chances of survival are only 10%. So, bache, always remember, any surgery done with an intention to save life is always justifiable, and a scar is always better than the news of that the patient has lost his life. So try to understand a scar is always justifiable if you are vigilant enough. So in any of them, the answer is you shall be going for surgery. Surgery irrespective of status, and this is what is very, 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 very important. The next is, when you talk about the blunt trauma, what to do in this case? When we are talking about the blunt trauma, the next thing is, again we need to understand whether the patient is unstable or whether the patient is stable. So stable versus unstable. Now this is again very, very, very important. If the patient is unstable versus stable, in penetrating we have seen, in this stable patient you can always go for CCT. Unstable patient, now you are like a ball rolling in between two courts. Should I go for surgery or should I continue with the conservative management? The answer to this question is, try to see whether there is any significant collection inside the abdomen. Why? Because if there is collection inside the abdomen and the patient is unstable, it is justified that there is some injury. And that is how we brought the focused assessment sonography of trauma. So in unstable patients, you will go for FAST. Remember, this is what is very, very important. FAST is the most useless investigation on planet. However, its importance is only in case of unstable patients, blunt injury, that it is not a diagnostic tool, students. It is not a diagnostic tool. It is not a diagnostic tool. The video has not hanged. I'm again and again telling you one point. It is not a diagnostic tool. It's only a decision-making tool. Because in FAST, you're only looking at the four quadrants, SRP, pouch of Douglas, and one window towards the heart. That is, you're going to look for the tampon heart. So if you think that the FAST is decision-making tool, then it is okay. And if you think that it's a diagnostic tool, you are a foolish person. Why? Because in FAST, you don't look at the organs. You just look at the pouches. Normally, there is no collection inside, or maybe hardly 10, 15, 20 ml of collection is free fluid is there in every patient. But if there is more than 150 to 200, it's significant. Unstable blunt trauma with significant collection, yes, it is. The second drawback of FAST is you're only looking at the peritoneal cavity. What about the retroperitoneal injuries? You're missing them out. So FAST negative doesn't rule out injury. You have to be vigilant. You have to be inquisitive that, okay, could it be a retroperitoneal organ injury or no? Yes, this is what is very, very, very important. So FAST, if the FAST is positive, you need to go for surgery. If the FAST is negative, what you need to do? Again, you need to repeat FAST. So repeat FAST. If the FAST is negative, always try to repeat it. And repeat FAST is done 30 to 45 minutes later. 30 to 45 minutes later. And this is what is very important. If this repeat FAST is positive, okay, it's done. If repeat FAST is negative, FAST after FAST is negative, then you will always have to sense that could it be a case of retroperitoneal organ injury. So in that case, you can go for serial hemoglobin plus PCV monitoring. So serial hemoglobin plus PCV monitoring is to be done. Now why? Because if it is a retroperitoneal organ injury, patient is going to bleed and there will be sequential drop in the hemoglobin and PCV. So if it is decreasing, then it is indicative of what, students? Retroperitoneal injury. So retroperitoneal injury, and if it is a case of retroperitoneal injury, then we need to go for surgery. If it is constant, then you need to go for observation. So students, I hope you enjoyed this video, and just it's Diwali, so I decided to create some buzz and teach you something. So now I will be regularly updating small crisp topic, and we'll be discussing it for the residents, for the MBBS students, for the patients, for everyone. So learning surgery is very, very easy, and with me you will just not only learn, you'll enjoy, and yes, surgery and swag, they go together. So I hope you enjoyed this video. Thank you. Do subscribe to my video. Do subscribe to my channel if you have not, and press the bell icon also. Till then, bye-bye.